somatic system, voluntary system. Somatic system means voluntary system. Your voluntary muscles will be weak. Your voluntary muscles will be weak. So this is your somatic nerve. So this is the somatic nerve of your somatic nervous system. We discussed already, somatic nerves are those which can release acetylcholine in the body, and acetylcholine is released in the body with the help of calcium ion that will take entry. So when the calcium will take entry, somatic nerve can release acetylcholine. Somatic nerve can release acetylcholine. Now this acetylcholine which is released by the somatic nerve, this will act on its receptor that is known as nicotine M receptor. And by acting on nicotine M receptor, somatic nervous system can result in muscle contraction. And after doing this muscle contraction, acetylcholine is metabolized. Acetylcholine is metabolized by one enzyme. The name of the enzyme is acetylcholine esterase enzyme. So this is what the physiology of somatic system we know. Somatic nerves release acetylcholine with the help of calcium ion. Acetylcholine will act on NM receptor, can result in muscle contraction. And finally, the acetylcholine is metabolized by acetylcholine esterase enzyme. This is what we people have discussed so far. Right? Now, this is physiology. Let's talk about the pathology. So, we talk about pathology. There are patients where the thymus gland is overactive. Condition is known as thymoma. So, in 80% of myasthenia gravis patient, 80% of myasthenia gravis patient, thymus gland remain overactive. So we people know that thymus is a gland which will regress with time. Thymus is a gland which will regress with age, but in some patients this thymus remain overactive. This will not regress, and once the thymus will not regress, this thymus is keep on producing antibodies. So this thymoma will produce lot of antibodies, and these antibodies will go and bind to the NM receptor. So antibodies will go and bind to the NM receptor, and when these antibodies will go and bind to the NM receptor, they will destroy the NM receptor, and now the acetylcholine cannot bind, antibodies will bind, and now they will destroy the NM receptor, and when the NM receptor is destroyed, the muscle cannot contract properly. Now what the muscle has to do? Muscle has to regenerate. Muscle has to regenerate the new receptor, and when this new receptor will come, again the antibody will destroy the receptor. So in this way the muscle will never get the strength properly and the muscles remain weak. So this is the problem. The thymoma is producing the antibodies. This is the myasthenia gravis. So what do? You know that ki antibodies are not allowing acetylcholine to act on the receptor. So what do? You will block this enzyme. You will inhibit acetylcholine esterase enzyme by giving a drug. The drug of choice is pyridostigmine. In case pyridostigmine is not given in MCQ, the alternative is neostigmine. So pyridostigmine or neostigmine you can give to the patient. They are inhibitor of acetylcholine esterase enzyme. Right? Now the acetylcholine level will be higher, and this acetylcholine level will come above the antibody level. Acetylcholine level will become more than the antibody level, and hence now the antibody cannot bind with the receptor because acetylcholine is more in number. So it will get a more chance to bind with the receptor. Antibody will not get a chance. So in this way, we will give pyridostigmine and neostigmine lifelong. We will give pyridostigmine, neostigmine lifelong to this patient, and his acetylcholine level we increase lifelong so that the antibodies are not able to bind to the receptor, and hence patient muscle strength remain maintained lifelong. So lifelong thymoma will produce antibodies. Lifelong you increase acetylcholine level, and hence you always allow acetylcholine to win the competition to bind with the receptor, and hence the muscle strength is maintained. Have you guys understood or not how these medicines will act? Now the problem is, just like a somatic nerve, we also have one more nerve in our body. That's a parasympathetic nerve. Now parasympathetic nerve is also a cholinergic nerve. This can also release acetylcholine. So parasympathetic nerve will also release acetylcholine. Now in parasympathetic system, acetylcholine will act on muscarinic receptor. So in parasympathetic system, acetylcholine will act on muscarinic receptor, and that will lead to that will lead to manifestation in the body, that is dumbbells. So this will lead to dumbbells as a manifestation in the body. Acetylcholine act on muscarinic receptor can lead to dumbbells. This is a parasympathetic system. Previous one was somatic system. Somatic system mein we have only one outcome, muscle contraction. Parasympathetic mein we have a outcome, we call it dumbbells. Now here in parasympathetic system also, acetylcholine is metabolized by the same enzyme, acetylcholine esterase enzyme. So as a result of that, what will happen? Whenever I give pyridostigmine, I want to stimulate somatic system. I want to stimulate somatic system so that the acetylcholine level will increase in somatic system. But unfortunately, what happens? This will also inhibit the enzyme of parasympathetic system, and these medicines will again increase acetylcholine in parasympathetic system where it was already normal, everything was normal, and now they have increased acetylcholine. Now this will act on muscarinic receptor excessively and can lead to side effect like dumbbells. So if the patient will take pyridostigmine and neostigmine, he will suffer from side effect like diarrhea, urination, low blood pressure, meiosis, bradycardia, bronchospasm. He will have all those problems. So he will have the cholinergic side effects because pyridostigmine, neostigmine given to stimulate somatic system, but they will also stimulate parasympathetic system. The reason is the both systems are cholinergic. So if one cholinergic is stimulated, the other will automatically get stimulated. As a result of that, what do we do to avoid this problem of side effect of medicines? Pyridostigmine, neostigmine can lead to dumbbells. What do? We give the low dose of atropine. So atropine is a medicine which is an anticholinergic medicine. It's a muscarinic blocker. This medicine is a muscarinic blocker. So this is the drug that is given along with pyridostigmine and neostigmine. So low dose of atropine is given to block the muscarinic receptor, and this is the medicine which is given to avoid the autonomic system side effect. So atropine is given along with pyridostigmine and neostigmine. Atropine is given along with pyridostigmine and neostigmine to avoid the autonomic side effect. So when we want to avoid the autonomic side effect, we need to add atropine to the above medicine. This is the best treatment that we give, pyridostigmine plus atropine. Now, there are some patients who suffer from a disease, we call it squamous cell carcinoma of lungs. So there are some patients who suffer from a disease, we call it a squamous cell carcinoma of lungs. So squamous cell carcinoma of lungs, here the cancer cell will act like a paraneoplastic cells. Squamous cell carcinoma of lungs, the cells will act like a paraneoplastic cells. They will act like a glandular cells. They start secreting antibodies. Squamous cell carcinoma of lungs, the cells will start behaving like a paraneoplastic cells. They start secreting antibodies, and these antibodies will destroy the calcium channel. These antibodies will destroy the calcium channel, and once they destroy the calcium channel, acetylcholine cannot be released. Acetylcholine cannot be released in the body, and hence the patient will have the muscle weakness. This disease is known as Lambert-Eaton myasthenia syndrome. This is known as Lambert-Eaton myasthenia syndrome, and thymoma is associated with myasthenia gravis. So thymoma, the strong association with myasthenia gravis, and Lambert-Eaton syndrome, the strong association with the cancer. Most commonly, it's a lung cancer. So we know that ki patient ka survival is poor. Patient will collapse in few years. Patient will die in few years. But till the time patient will not die, we can improve the quality of life. So how we can improve the quality of life? I can give pyridostigmine to the patient. I can give pyridostigmine to the patient. So although the release of acetylcholine is less, but whatever acetylcholine is coming out, I will not I will not allow this acetylcholine to get metabolized. So I will stop its metabolism. So even the small amount of acetylcholine stay in the synaptic cleft for a long time, and now this can improve the muscle strength. So pyridostigmine, neostigmine, by inhibiting the metabolism of acetylcholine, will allow the acetylcholine to act for a long time, and hence we can improve the quality of life of this patient who is already going to collapse in few months or maybe few years, but at least we can improve the quality by giving the drug pyridostigmine and neostigmine. Got it, guys? Now, here you people have to understand one physiology concept. And according to the physiology concept, if there is any cell of the body, like this is any cell of the body, if any positive charge takes entry in a cell, if any positive charge will take entry in a cell, the cell get depolarized. If any positive charge will take entry in a cell, the cell get depolarized. But if any negative charge will take entry in a cell, the cell get hyperpolarized. If any negative charge will take entry, the cell get hyperpolarized. If any positive charge will take entry in a cell, the cell get depolarized. Now the vice versa is also true. If any positive charge, if any positive charge will go out of the cell, if any positive charge will go out of the cell again become hyperpolarized. And if any negative charge will go out of the cell get depolarized. So please tell me how many of you have understood this point. Okay, you people have asked some question. Venkatesh has asked, is thymoma is the most common etiology of myasthenia gravis? Like not the etiology, association. Association you can say 80% may it's a maximum, like most commonly associated problem with myasthenia gravis, that thymoma is there. Yes, the answer is yes. Whatever is your question, the answer is yes. And second question, Dr. Nischal has asked, squamous cell carcinoma can cause hypercalcemia. So how does it destroy the calcium channel? No, I didn't get the question. Squamous cell carcinoma can cause hypercalcemia. So how it is related to the calcium channel? Like calcium channel is destroyed by the antibodies, and retention of calcium is through, I think, through kidney. That's a different thing. So no relation, guys. So if we talk about any cell, when positive charge enters in a cell, the cell get depolarized. When negative charge enters in a cell, the cell get hyperpolarized. Obviously, interior of the cell is important. When the positive charge takes entry in a cell or negative charge comes out, the cell ka jo interior hai, that will become positive, the cell get depolarized. But if a negative charge enter in a cell or the positive charge go out of the cell get hyperpolarized. Okay, Prashant Bhushan has understood. Venkatesh, I hope you have also understood second time. Okay, Prashant, tell me one thing. If a chloride ion will take entry in a cell, if a chloride will take entry in a cell, what will happen to the cell? If chloride will take entry in a cell, what will happen to the cell? Depolarized or hyperpolarized? If a chloride ion will take entry in a cell, the cell get hyperpolarized or depolarized? Hyperpolarized. Very good. Now my second question, if a sodium and calcium will take entry in a cell, if a sodium and calcium takes entry in a cell, the cell get depolarized or not? What will happen to the cell when the sodium and calcium will take entry? So when the sodium and calcium will take entry, the cell get depolarized. Very good answer. So this is what is happening here. You can see the calcium is taking entry. So when the calcium will take entry in a neuronal cell, so this is a neuronal cell. When the calcium takes entry, the cell get depolarized and will release the acetylcholine. Now, my question is, normally what happens? We have a excessive potassium present inside the cell. Potassium ka level is normally more inside the cell than the outside. So when the potassium goes outside the cell, what will happen to the cell? Potassium is a positive charge. When the cell will lose the positive charge, when the cell will lose the positive charge, the cell get hyperpolarized. Cell get hyperpolarized. So here in this neuron, if you look at carefully, when the calcium takes entry, the cell get depolarized, and in the response of this, equal amount of potassium goes out to repolarize a cell. Calcium takes entry, the cell get depolarized. Potassium goes out, the cell get repolarized. So we have a drug with us. The drug name is emfempridine. We have a medicine. The drug name is emfempridine. And emfempridine is a medicine which is a potassium channel blocker. This is a potassium channel blocker, and this will depolarize this neuron and can release acetylcholine excessively. So this is the medicine which is a potassium channel blocker, and by blocking the potassium channel, this will allow more acetylcholine to released, and this is the drug of choice for Lambert-Eaton myasthenia syndrome. This is the best medicine for Lambert-Eaton myasthenia syndrome. We call it a potassium channel blocker. So pyridostigmine is a second drug of choice for Lambert-Eaton syndrome. Emfempridine is a medicine. This is only for those students who are preparing for INSCT. So only for INSCT students, this LEMS topic is important. LEMS is only for INSCT. Myasthenia gravis is asked in NEET exam also. NEET exam में myasthenia gravis is asked. INSCT में they can go one step ahead. So Lambert-Eaton syndrome is only for INSCT people. So Lambert-Eaton syndrome, the best medicine is emfempridine. So emfempridine is a potassium channel blocker. This is a potassium channel blocker, and by blocking the potassium channel, this will not allow potassium to go out of the cell. And when this will not allow potassium to go out of the cell, the neuron will get depolarized. All the potassium remain inside the cell. The neuron get depolarized, and when this neuron is depolarized, this will release more acetylcholine. You people have to understand कि Lambert-Eaton syndrome में we cannot release acetylcholine by calcium. We cannot depolarize a neuron to release acetylcholine in Lambert-Eaton syndrome to release acetylcholine. We cannot depolarize by calcium. So how we can depolarize a nerve to release acetylcholine in Lambert-Eaton? Answer is by blocking the potassium channel. So emfempridine is a potassium channel blocker. This is the best medicine to be given in patients of Lambert-Eaton syndrome to release acetylcholine. Now let's come back to the myasthenia gravis. Myasthenia gravis का जो patient है, management of myasthenia gravis. So management of myasthenia gravis. So patient of myasthenia gravis can come to you in three types of scenario. Patient can come to you with local muscle weakness. Patient will come to you with generalized muscle weakness, or patient will come to you in acute emergency. This is an acute emergency. We call it myasthenia crisis. So three presentation of myasthenia gravis. Localized muscle weakness. Most commonly, eye muscles are involved. You must have covered in ophtha also. You must have covered in ophtha. The eye muscles are most commonly involved. Now, the patient may have the multiple muscles involved. Patients may have the multiple muscles involved. And although the multiple muscles are involved, we are concerned about only one muscle group. Whenever patient के multiple muscles involved होते हैं, we are very much interested in knowing कि respiratory muscles are involved or not involved. So this is the most important thing to consider कि respiratory muscles are involved or not involved, right? So when the patient has got a local muscle weakness, the disease severity is low. So I will start pyridostigmine or I will start neostigmine. This is what we people have covered. I will start pyridostigmine. We start pyridostigmine or neostigmine, right? This is given with low dose of atropine, right? So pyridostigmine and neostigmine, these medicines are given with low dose of atropine. It is given with low dose of atropine. So pyridostigmine, neostigmine, these medicines are given with low dose of atropine as a first group of treatment, first line of treatment. Now, when the patient conditions are not controlled or patient condition does not improve, when the patient condition does not improve, not controlled by giving pyridostigmine, what we have to do, we have to add immunosuppressant in the patient treatment. We have to add immunosuppressant in the patient treatment. So immunosuppressants are those medicines that will reduce the antibody count. So this will reduce the antibodies in the plasma. So immunosuppressants are added in the patient treatment if the myasthenia gravis is not controlled by pyridostigmine or uh, neostigmine with atropine combination. Then we have to add the immunosuppressants. Right, guys? Now, here you people have to remember one rule. The rule is whenever we treat any disease in medical science, whenever we treat any disease in medical science, whatever first drug you will give, that first drug is known as drug of choice. So whatever first drug is given, and that drug will treat the cause of the condition. Whatever first drug you will give, that drug will treat the cause of the condition. That's a best medicine of the disease. We call it a drug of choice. Now, after giving drug of choice, if the patient condition is not controlled, after giving the first medicine, that will treat the cause of the condition. If that is not controlled, the disease symptoms are not controlled, then please remember, guys, do not stop the first medicine. Do not stop the first drug. Always add the second medicine. Do not stop the medicine. Always add the second drug with different mechanism of action. Always add the second medicine with different mechanism of action. So the second medicine should act by different mechanism of action. And there is a strong exception. The exception is antimicrobials. So this rule is not applicable to antimicrobials because antimicrobials are not against human disease. Antimicrobials are against microbes. Antimicrobials वो drugs हैं which are not given for human mechanism. They are given for bacterial mechanism. The exceptions are antimicrobial. Antimicrobial में when the first drug will fail, we stop the first drug. It means वहां पर resistance है. In antimicrobial, when the first drug will fail, we stop the medicine, assuming the resistance is there, and we replace the drug. But otherwise, फिर apart from antimicrobial, for all disease in medical science, whatever first drug is given is a drug of choice. If that medicine is not able to control, you do not stop the first drug, you continue the first drug, always add the second medicine. Now, based on this knowledge, you people have to tell me what is the second drug of choice for myasthenia gravis. What is the second drug of choice for myasthenia gravis? Is it neostigmine or immunosuppressant? What is the second drug of choice for myasthenia gravis? So you have given pyridostigmine. Now, if the pyridostigmine is not able to control the disease, will you add neostigmine or you add immunosuppressants? Yes, the answer is immunosuppressant. So this is how you people have to remember that neostigmine is alternative. Like in case you don't have the pyridostigmine available, pyridostigmine का supply नहीं आ रहा पीछे hospital में, then you can give neostigmine as an alternative. So neostigmine is alternative, right? Then and the immunosuppressant is a second drug of choice that we can add in the patient treatment. Okay, now let's talk about the generalized muscle weakness. Any patient who has got a generalized muscle weakness. Now here in this patient, we start the drug therapy. We start the drug therapy like we discussed before, pyridostigmine plus atropine. Now along with drug therapy, we have to remove the thymus. We have to remove the thymus. We have to go for thymectomy. So surgery is also advisable. So we have to go for drug therapy plus surgical therapy. So we have to remove the cause also because this cause is become the life threatening now. Right now, after removing the thymus and starting the drug therapy, still the patient condition is not controlled. Still the patient condition is not controlled. It means the other lymph nodes are also involved. So when the after removing the thymus, if the patient condition not controlled, it means apart from thymus, other lymph nodes may be producing the antibodies. So now you have to add immunosuppressant in this patient treatment. You have to add immunosuppressant in the patient treatment, but you should also understand the patient prognosis is very poor. So you have to do the proper counseling and you have to tell the patient to sign all the property papers because there are very less days which are left and this can lead to property dispute after him. So better to do all formalities whatever are possible. Right, guys? Now let's talk about acute crisis of myasthenia gravis. So how the patient presented to you? So patient is a known case of myasthenia gravis and patient is already on the treatment. So patient is a known case of myasthenia gravis and he is already on the treatment. He is already taking pyridostigmine, right? Now what will happen? He suddenly gets some infection. He has got some non-specific infection like he has got a tonsillitis. He may have got a seasonal fever, seasonal flu हो गया. Patient को viral fever हुआ, seasonal flu हुआ. Patient got tonsillitis. Now because of this infection, patient lymph nodes become overactive and they start producing lot of antibodies. So patient has got lot of antibody production in his plasma due to this precipitating factor, and that has precipitated the disease. This is known as myasthenia crisis, right? So on urgent basis, you have to remove antibodies. You have to remove the antibodies as soon as possible in this patient, and the fastest way of removing the antibodies is plasmapheresis. If that is not available, the second fastest way of removing the antibodies is, or suppressing the antibody, is intravenous immunoglobulin. And if that is also not available, the last way is methylprednisolone. So these are the three options we have: plasmapheresis, intravenous immunoglobulins, and methylprednisolone. These are the three types of, these are the three treatment modalities we have by which we can suppress the antibodies. Plasmapheresis is the fastest way, followed by the intravenous immunoglobulins, then the methylprednisolone we can use. Right, guys? Now, please remember, in myasthenia crisis, pyridostigmine we don't give. In myasthenia crisis, pyridostigmine has no role. So we don't give pyridostigmine because pyridostigmine can reduce the BP. Pyridostigmine can cause bronchospasm, and the patient is already unstable, and that is something we don't want. So pyridostigmine we don't give for myasthenia crisis. Rather, if the patient is already taking pyridostigmine, we stop it for few days. We stop pyridostigmine for few days because pyridostigmine can make the patient more unstable. Pyridostigmine can make the patient more unstable. So pyridostigmine is avoided. We can remove antibodies by plasmapheresis, intravenous immunoglobulin, or by methylprednisolone. So this is the treatment of myasthenia gravis. So Fatima is asking which neurotransmitter is released in CNS by sensory nervous system. अरे फातिमा, CNS पे कहाँ पहुंच गया? Sensory system में कौन सा neurotransmitter release होता है? So we have the multiple neurotransmitters, like not one. That depends कौन सा sensory nerve activate हुआ, which pathway is activated. Like I'll give you example, Fatima. For example, when the pain pathways are activated, then this will lead to release of opioids in the CNS. तो body में release होते हैं opioids. So those are the neurotransmitters. Got it? In this way. ऐसे ही sometimes acetylcholine is released. Sometimes the prostaglandins are released. Nitric oxide is released. So multiple neurotransmitters are released by the sensory nerves, right? So that is difficult to tap. And because that is difficult to tap, we don't have any treatment modality by which we can block the sensory system by blocking the neurotransmitter. Vidya Saheti, Vidya wants to know, can we give IV antibodies? Acha, ye IVIGs you want to say? Vidya, IVIG full form is intravenous immunoglobulins. These are the blank antibodies. Their structure resemble antibodies. The structure of this chemical resemble the antibodies, but they are not against any target. So when I inject these medicines in plasma, they will act like an antibody. The structure is like an antibody. This will give negative feedback to lymph nodes. But they will not destroy any target. So they are the blank antibodies. We call them the intravenous immunoglobulins. Intravenous immunoglobulins, blank antibodies, and they will give a negative feedback to lymph nodes, but they will not against any target. So anyone from Maharashtra or Pune? Anyone here from Maharashtra, Pune? Or everyone is from South India? Anyone from West India, Maharashtra, Pune? कोई मराठी मानुस है यहाँ पे? Pavan, we don't give pyridostigmine and neostigmine in myasthenia gravis. Myasthenia gravis में we don't give pyridostigmine and neostigmine. I told you that will make the patient more, yes. So patient become more unstable. Crisis में patient already unstable है, and we are doing the procedure already. Narayana, above treatment is expensive. I agree with you. That's why I've given you a sequence. Like if you're working in hospital like AIMS, तो आपके पास plasmapheresis होता है. But in case you are not working in AIMS, you are working in some state hospital, then you don't have the plasmapheresis available. So IVIG nowadays people can afford. Or NGOs are giving IVIGs. I know that कि villages में IVIGs are, I mean, difficult थोड़ा सा, but metro cities में IVIGs anyone can afford. Now in case that is not there, तो methylprednisolone is a very cheap alternative, so that we can try. हाँ, तो मराठी मानुस बताएंगे. मराठी मानुस will tell me the answer. महाराष्ट्र में and पुणे में recently there was a outbreak of that disease, GV syndrome. So what is the best treatment for GB syndrome? GB syndrome में again the problem is antibodies are formed. What is the best treatment? Which medicines will give you the fastest relief in GB syndrome? Which medicines provide fastest relief in GB syndrome? Very good. The answer is IVIGs. So IVIGs are the medicines. जैसे plasmapheresis क्या करता है? This will remove antibodies within few hours, within 3 to 4 hours. IVIG suppress the antibodies in 1 or 2 days. Methylprednisolone suppress antibodies in 3 to 4 days. इतना फर्क है. Just only the days of in the only the matter of few hours and few days. Okay, now there is a table given in your Harry. So according to the Harry, there are few medicines that you should avoid in myasthenia gravis. So which medicine you should avoid in myasthenia gravis? The mnemonic is ABMCQ. The mnemonic is ABMCQ multiplied by 2. Not a good mnemonic. So ABMCQ. So two medicines starts with A, should not be given in myasthenia gravis. One is aminoglycosides. One is anesthesia drugs. So aminoglycosides and anesthesia drugs should not be given in myasthenia gravis. These medicines block the neuromuscular junction and make the muscles weak. So aminoglycosides like streptomycin, gentamicin block the neuromuscular junction. Anesthesia drugs like the local anesthetics, general anesthetics, skeletal muscle relaxants, they will block the neuromuscular junction and make the muscles weak. So A stands for aminoglycosides, anesthesia. B stands for beta blocker and Botox. So beta blockers and Botox also make the muscles weak. Now the C stands for calcium channel blocker. C stands for calcium channel blocker and the ciprofloxacin. Ciprofloxacin and calcium channel blocker. These medicines are starting with C. And then we have M. Sorry. A is for aminoglycosides and anesthesia. B is for beta blocker and Botox. Then we have M. M is for magnesium sulfate and macrolide. M is for magnesium sulfate and macrolides. So macrolides mein we have a drug erythromycin. Erythromycin should not be used in myasthenia gravis. And C is for calcium channel blocker and Ciplox. And Q is for quinine and quinidine. Q is for quinine and quinidine. So I'm so sorry for this mnemonic. Like they have not given it properly, right? So ABMCQ is a mnemonic. A is for aminoglycosides anesthesia drug. B is for beta blocker and Botox. M is for magnesium sulfate and macrolide. C is for calcium channel blocker and Ciplox. Q is for quinine and quinidine. These medicines are avoided in myasthenia gravis. So not a good mnemonic. So you should not make this kind of mnemonic like ABCD, ABMCQ. You people cannot recall in the exam. Like after studying 19 subjects, कितने ABC याद करोगे? How will you recall कि pharma में myasthenia gravis का A क्या है, B क्या है, C क्या है? तो exam में it's difficult to recall ABC. Exam में when you sit, you become C in the exam. है ना? आप C बन जाओगे exam में. याद ही नहीं आएगा C क्या है. C is cute बन जाओगे exam में ना? Cute बन जाते हैं. याद ही नहीं आता क्या है. So it's better to make mnemonics which are of relevance, right? So not a good mnemonic, but still this is the only mnemonic I have. Okay. Now you people have to understand that magnesium sulfate is a drug that can release magnesium. Now body cannot differentiate between magnesium and calcium. Body cannot differentiate between magnesium and calcium. So magnesium will bind to the calcium channels and stop the calcium entry and make the muscles weak. So whenever I give magnesium sulfate, magnesium and calcium, body cannot differentiate. So magnesium will go and occupy the calcium channel, block the calcium entry and make the muscles weak. This is the mechanism of action of magnesium sulfate. Okay guys. So magnesium sulfate block the calcium entry in your neurons. It's the best medicine for eclampsia. Magnesium sulfate is the best medicine. Differentiate between magnesium and calcium. Body cannot differentiate between magnesium and calcium. So magnesium will bind to the calcium channels and stop the calcium entry and make the muscles weak. So whenever I give magnesium sulfate, magnesium and calcium body cannot differentiate. So magnesium will go and occupy the calcium channel, block the calcium entry and make the muscles weak. This is a mechanism of action of magnesium sulfate. Okay guys. So magnesium sulfate block the calcium entry in your neurons. It's a best medicine for eclampsia. Magnesium sulfate is a best medicine for eclampsia. Stop the epilepsy. E is for eclampsia, E is for epilepsy. Stopped by magnesium sulfate by blocking the calcium entry. Now if I say magnesium sulfate block the calcium entry in neurons, can result in muscle weakness. You know that when we give magnesium sulfate in eclampsia, deep tendon reflex is gone. So I'm talking about which calcium channel. Is it a L-type calcium channel blocker or it is a T-type calcium channel blocker that is present on nerves? Magnesium sulfate block the calcium entry by occupying which calcium channel? T-type or L-type? Is it a blocker of T-type calcium channel in neurons or L-type calcium channel? Answer is T-type calcium channel blocker. And by blocking the T-type calcium channel, this will stop the release of acetylcholine. And by stopping the release of acetylcholine, this can result in muscle weakness. So this can result in muscle weakness. Now, I would like to ask one question from you people. You people must have got L-type calcium channel blocker or it is a T-type calcium channel blocker that is present on nerves. Magnesium sulfate block the calcium entry by occupying which calcium channel? T-type or L-type? Is it a blocker of T-type calcium channel in neurons or L-type calcium channel? Answer is T-type calcium channel blocker. And by blocking the T-type calcium channel, this will stop the release of acetylcholine. And by stopping the release of acetylcholine, this can result in muscle weakness. So this can result in muscle weakness. Now, I would like to ask one question from you people. You people must have got dyspepsia in your life. Obviously, everybody gets dyspepsia. Dyspepsia means indigestion. So layman people call it gastritis. So gastritis is not a proper word. The proper word is dyspepsia. So whenever you people get dyspepsia, you people take antacid. The brand name of antacid is Digene. So guys, any one of you have taken this antacid Digene? Any one of you have taken this antacid? The brand name is Digene. Digene is a brand name. If you have ever taken this antacid, so if you have ever taken this antacid Digene, what is the salt present in this Digene? Can any one of you tell me? कि डाइजिन का सॉल्ट क्या है? Digene contains which salt? It's an antacid. It is an antacid that you people take when you have dyspepsia. What is the salt present in this Digene? Okay, yes. So you can see this is the Digene. I have just brought the bottle from my pictures. So this is the magnesium hydroxide and aluminum hydroxide. It's a combination of magnesium and aluminum hydroxide. It is a combination of aluminum and the magnesium hydroxide. So this is a Digene. So this is the magnesium containing drug. You people have to understand this is a magnesium containing drug. Similarly, there is a drug known as milk of magnesia. Now, milk of magnesia is a drug that we use for constipation. And this is given in the form of enema. So milk of magnesia is a drug for constipation that we give in the form of enema. Digene is an antacid that will neutralize the acid in the lumen of GIT. Now, these two are the magnesium containing preparation, milk of magnesia and antacids, which are not absorbed in systemic circulation. So they are not absorbed in systemic circulation. And when they are not absorbed in systemic circulation, so there is no systemic absorption of this magnesium. So this is the magnesium of Digene and milk of magnesia that will not go to systemic circulation. As a result of that, these medicines are safe to use in myasthenia gravis. These medicines are safe to use in myasthenia gravis. They will not interfere with the calcium of the nerves and hence they are safe to use in myasthenia gravis. So be careful. They can give you magnesium sulfate, that is unsafe because magnesium sulfate is given by the parental route, but the other magnesium we can give by the local route. So those medicines are safe, but these medicines are unsafe. So this table I have taken from Harrison. So A is for aminoglycosides and anesthesia drug. B is for beta blocker and Botox. M is for macrolides and magnesium sulfate. C is for Ciplox and calcium channel blocker. Q is for quinine and quinidine. Right, guys? So these are the medicines that we avoid in myasthenia gravis. Now, snake bite, you people have already covered. Snake bite, you people have already covered in your forensic medicine. So three type of snake: cobra bite, viper, and sea snake. Cobra is neurotoxic that will block the neuromuscular junction. Cobra bite is neuromuscular junction blocker, neurotoxic snake, and the patient will have the muscle weakness. So patient will have the muscle weakness. Viper is vasculotoxic. V is for V. Viper is vasculotoxic. V is for V. So that will not allow the blood to stop. Patient will die due to hypovolemia. Patient का death होगा because of hypovolemic shock. Patient will have the bleeding. Patient will have the hypovolemic shock. This is a vasculotoxic bite. Now, sea snake is myotoxic. Sea snake will cause rhabdomyolysis. Rhabdomyolysis means the muscles damage. Now, when the muscles will damage, the muscle protein will come out in plasma. Muscle का जो protein है, that will come out in plasma, and this muscle protein will go and clog the kidney. अभी kidney में जाके deposit होगा, that will cause the AKI. तो patient का kidney is failed. Patient का kidney is failed. So the best treatment for snake bite is anti-snake venom. Best treatment for snake bite is anti-snake venom. It's the best treatment of choice. But apart from anti-snake venom, in patients of cobra bite, I can give neostigmine. So in patients of cobra bite, I will give neostigmine with low dose of atropine. So I will give neostigmine with low dose of atropine. So neostigmine, which is a fast-acting medicine given for cobra bite after anti-snake venom. So after anti-snake venom, I will give neostigmine with low dose of atropine for the treatment of cobra bite. Right? Now for these patients, for the viper bite, I will give anti-snake venom. I will give lot of IV fluids. So lot of IV fluids are given to replace the loss of blood. So whatever blood is getting lost, we will replace with IV fluids, or I can give the blood components. I can give the blood components whatever are getting lost. So whatever is inhibited, like platelets का deficiency है, I can give platelets. Clotting factor deficiency, I can give clotting factor. So whatever is deficient, I can give blood component to the patient. Now in sea snake, I know that I will give anti-snake venom, but the myoglobin is going to the kidney and blocking the kidney. So what I can do, I can give lot of IV fluids. And when I give lot of IV fluids, that will cause rapid flushing out of this myoglobin. So this will cause rapid flushing out of myoglobin. So myoglobin is rapidly flushed out. Myoglobin is rapidly flushed out of the kidney when you give lot of IV fluids. So lot of IV fluids will increase the urine, increase the GFR, and myoglobin will not clog the kidney, will not block the kidney tubule, and hence this is rapidly flushed out. So you can see only in one snake bite the drug has a role. Only in one snake bite we give a drug, that is cobra bite, where we give the neostigmine. Now can any one of you tell me why I am giving atropine here? Cobra bite में along with neostigmine, why I am giving atropine? Can any one of you justify this treatment which I am giving to the patient? Why I am giving neostigmine with atropine? Any idea? What is the role of atropine here? Now, after the snake bite, we have Alzheimer's disease. Very good. So all of you have given the correct answer, to block the muscarinic side effect. So we give atropine to prevent the muscarinic side effect, to dumbbells as a side effect. Very good. Now next is Alzheimer's. Alzheimer's, we people have discussed the